afternoon, and good morning to those on the West Coast. Welcome to today's webinar, Strengthening Health and Housing Partnerships Through Medicaid to Improve Healthcare for Individuals Experiencing Homelessness. Thank you to all of you who are taking the time out of your busy schedules to spend part of your Monday with us. My name is Charles Townley, and I'm a Project Director for the National Academy for State Health Policy. I will be today's moderator. Before we begin, I'd like to take this opportunity to thank the Health Resources and Services Administration, without whom this work would not be possible. We do have an upcoming paper that is tied to this webinar topic, and we expect that will be released in tomorrow's newsletter. So for today's agenda, participants will have the opportunity to engage with Marcella McGuire, Director of Health Systems Integration at CSH, the Corporation for Supportive Housing, as well as leaders from New York and California. After Marcella provides an overview of the importance of this topic and state strategies, we'll hear from Elizabeth Misa and Brian Hansen. Elizabeth is the Deputy Medicaid Director for the Office of Health Insurance Programs within the New York State Department of Health, and Brian Hansen is a Health Program Specialist, too, at the California Department of Healthcare Services within the Healthcare Delivery System Division. Following the presentations, we'll open up the discussion to audience Q&A. Before we begin, just a few quick notes. If you are having audio issues or if you develop audio issues during the call, you can hear the audio by calling in 1-888-632-5004 and entering conference ID 250030. The slides and a recording of the webinar will be available at nashb.org within the next few days. All lines are muted, so please submit your questions using the chat box, which you can find at the bottom left corner of your screen. And if you're in full screen mode, you may need to go into a windowed mode to see the chat box. And questions are going to be reserved for the end of at the end of the presentations, but please submit them at any time, and we will ask them once we open up Q&A. So with that, I would like to introduce Marcella. The floor is yours.
All right, thank you so much. And Charles, thank you to yourself, and Dory and Clary, the great folks at NASHBIT, for this opportunity to engage around this incredibly important topic. I'm going to be talking today from a national perspective about the many wonderful pilots, initiatives, and great thinking that's going on around the country to bring together the health and housing sectors in order to serve people with complex care needs, what might have been called a little while back the high-cost, high-need population, and in people experiencing homelessness. So thank you for this great opportunity. I want to make sure folks are well aware of CSH. CSH is the source for housing solutions. We're a 25-year-old national nonprofit, an industry leader, an experienced bridge between the healthcare and housing sectors. We do 4 lines of business: lending, we're a community development financial institution, as well as policy reform, training, and consulting and technical assistance. We're in 22 field offices across 13 states, and as well as working with 47 of 50 states at this point. So have a really good, nice brand and engaged around this work, particularly with the national team as well as the field offices that are really embedded in their communities and supporting this work at the local community level. For the Nashville audience, I want to give you just a brief understanding of some of the work that has been happening for decades around the homelessness sector. There's a national report that's done every year, what's called the point in time, where you'll hear them called pit counts. Communities every year go out and engage. Shouldn't say every year, every other year is required by HUD for funding, required to count how many people are experiencing homelessness. HUD in their communities. HUD has a very strict definition of homelessness that we'll talk about a little bit. Our most recent annual report is the 2015 report that indicates almost 550,000 people are experiencing homelessness in this country. That's a point in time. That's a one-night number, not over an annual number. You'll find the annual number in what's called the AHAR report, the Annual Homelessness Assessment Report to Congress. We find most commonly and more of data integration projects are finding a common intersection with complex care populations. So while the housing and homelessness sector may be concerned about the people experiencing homelessness, people experiencing unstable housing in their community, the healthcare sector is concerned about the complex care population. We see a lot of overlap between these two populations. We see people with behavioral health challenges are overrepresented in both groups, and it's important to make a distinction between the fact and understanding that most people's homelessness self-resolve quickly. A small portion of individuals are chronically homeless. homeless. HUD has spent the last, I would say, 3 to 5 years coming up with a very precise definition in regard to chronic homelessness. That definition includes both what we call longevity, meaning individuals have been homeless for a year continuous, and or they've been homeless for 4 episodes of homelessness in 3 years. That adds up in that time to a full year. And they also have a disability. And it's important to remember that in the HUD definition of chronic homelessness, substance use disorders count as a disability, unlike most other federal departments. So individuals who are experiencing chronic homelessness have a long time homeless and a significant and severe disability. Veterans in chronic homelessness both fell significantly in recent years when there was dedicated resource to that. Folks may have heard in their communities about the VASH program, which is the Veterans Administration Supportive Housing, where HUD was funding subsidies and the VA was funding services. Chronic homelessness also had significant resources put into supportive housing in the last number of years, and that also gave us significant decreases. And you've got 2 links here on this new PowerPoint as it goes out. One is to the AHAR, and one is to the National Alliance to End Homelessness' annual report on the statistics. So that's just a little blurb about all the work that's going on out there in communities. The healthcare sector comes to this work from a social determinants of health perspective, and I think that's something a lot of people are hearing about now. But people are understanding that in order to have the impacts on population health, on health inequities and health disparities, there needs to be a focus on to move beyond the clinical care, to move the hospital and the clinic and into the community. And that's where often housing comes in. There are other work being done in social determinants of health, work being done around nutrition, work being done around schools. But housing seems to be just an absolutely key and fundamental platform for impacting the social determinants of health and moving towards the healthcare outcomes for all Americans. Just a little blurb to help people understand and remind folks why health matters. These are all, I think, very basic. 1, poor health puts someone at risk for homelessness. And homelessness puts one at risk for poor health. The ability to manage a chronic condition when one is not sure, when you're sleeping every night, when you're not sure that you'll have access to, say, a refrigerator for your diabetes medication, when you don't have a stable address, and so information about how to keep your benefits moving forward goes to different places. You may or may not follow up with those directions and requirements because you haven't been able to access to the mail. Unstable housing and homelessness complicates efforts to treat illnesses, to treat injuries. They make continuity of care extremely difficult for the individuals suffering from challenges and disorders. And we find that when individuals are often able to come into housing, able to come into supportive housing in particular, the ability for them to have continuous continuity of care, similar treatment providers is just a really essential change. Somebody that stops looking at them as a one point in time as you think about an emergency department and looks at the whole picture of health as healthcare providers are doing more and more. For that chronically homeless population, again, a very small segment of people experiencing homelessness. For that complex care, chronically homeless population, the proven solution is supportive housing. And the link here gives you all of the research and all of the evidence that we've found over the years in regard to this space. This is a picture in my hometown of Philadelphia of Project Homes Francis House of Peace, or 810 Arch Street. I will tell you why some of these projects are so difficult to do, difficult to put together, because most commonly they are put together with what's called braided funding, meaning multiple funding streams and multiple funding strategies are put together. Project Homes 810 Arch has 3 unique affordable and supportive housing funding streams, as well as 2 unique supported services funding streams, as well as private money to fill in all of the links in between. So it really takes an incredibly sophisticated provider to do one of these buildings. It's important to know it doesn't just have to be a building model. There's 3 basic models of supportive housing, what we call the project-based, which is what 810 Arch and other buildings are like, where everyone in the project is in the building is part of the program. You also have what are called scattered site models, where individuals take a rental subsidy and can use that rental subsidy on the open market with supportive services coming in. And then finally, you have community integrated models in which a portion of the project, a portion of the units in a building may be dedicated to people with disabilities with supportive services attached. So in a 100-unit building, you may have 10 units or 25 units, and that would be a more community integrated project. Anybody who's worked for government, as I have, worked at the federal, the state, or local level, knows how very hard it can be to align these funding streams, to align these funding strategies. And so that's a lot of why supportive housing is very difficult to put together, and it's taken extraordinary leadership at the local level. And I think over the last number of years, between the folks at HUD, the folks at ASBE, Medicaid, USICH, have all been trying to look at these federal funding streams and how to align them so that it's easier to put together more of these projects, and because the need is so clearly there in the complex care populations, in the chronically homeless populations. And we're excited for the flexibility that's coming with this current administration to see what the options and opportunities will be there as well. But as anybody who's worked, as I said, in government, braiding funding streams, aligning funding streams, working cross-sector can be an enormous challenge. I'm going to talk about some of the early efforts that have been done to move this statewide. I would say the two earliest that we're aware of is, and must highlight, the state of Louisiana post-Hurricane Katrina, when at the state level they were able to coordinate and braid multiple funding streams, both from HHS and HUD, including a 1915C waiver for home and community-based services, as well as a rehab option to use assertive community treatment teams and pair that with affordable housing in the community in order to create supportive housing. Massachusetts used an 1115 waiver to create their what's called CSPEC program, community support program for people experiencing chronic homelessness. That was a collaboration under the 1115 waiver between MAHASA, the statewide trade organization for supportive housing and homelessness services, and Massachusetts Behavioral Health Carve-Out, or MDHP. And that started as a 50-slot program. That's now become a statewide benefit under the last iteration of that. 11 states that have used 1115 waivers in order to do this include California and New York. We'll hear more details about them from our two other presenters. Indiana has an 1115 waiver for what we're calling the supportive services or foundational community supports. Indiana is focused on the substance use disorder population. Maryland has a small project focused on their money follows the person population, or individuals leaving institutional care, such as nursing homes, and helping them transition into community living situations. And then Washington State has focused on people with experiencing chronic homelessness, and to my knowledge, that program is in the last stages of collaboration with CMS for how that program will be structured, and that should be moving forward again shortly. Next slide, here we go. 4 states that we're aware of currently have 1115 requests to CMS in order to do foundational community supports programs: Florida, Illinois, New Jersey, and Rhode Island. Rhode Island and Illinois are both focused on a behavioral health population. New Jersey is also focused on a behavioral health population, but also a piece of looking at individuals transitioning from the criminal justice system back into the community that are likely, given the level of disability they've seen in their long-term incarceration, to need supportive housing. And Florida is also focused on a central Florida population around the Orlando area, where there's a very, very high level of chronic homelessness, and a great stakeholder group put together to engage and enjoy. Michigan and Pennsylvania have both used their managed care waivers through the 1915B3 waivers, also in order to engage the housing sector and organize resources to help individuals transition to the community. Sometimes that's transitioning out of institutions such as psychiatric state hospitals, such as nursing homes, such as intensive care facilities, or ICFs for the DD population. At other times, it's been trying to assist individuals to move out of group home settings so that another group of individuals may be coming from the state institutions there. So that's another waiver that's been done. And all of this information is available on, I have some links here to both the CMS website as well as state websites with some of these details. I'm going to skip this slide because you're going to get more details in California and New York here, but really strategically chosen, I think, for this webinar because they have some of the most broad-reaching, far-reaching projects coming forward, and also some good links to where you can get some more about that. But shout out to California for their whole person care pilot, which is kicking off this year, and New York did a very intensive 2 to 3 year planning process looking at using state savings from their global cap to invest in supportive housing. Some projects are already up at this time and showing some outcomes, so I'm excited to hear about this as well from our other presenters. And just to share some other links with individuals for the 2 states that have been doing this long term. Louisiana, as we said, was begun in the aftermath of Hurricane Katrina. At the state level, Louisiana braided funding from multiple HUD funding streams, as well as SAMHSA, HRSA, and Medicaid. The Louisiana project's been allowed to show some really great outcomes, and shout out to the brief, the NASHB brief in this topic, where they were able to reduce costs 24%, primarily due to decreases in institutional care costs. This is looking at what the cost of supportive housing is, what the cost of institutional care is, and see from a bottom line state budget perspective what has to show as the greatest cost savings. It's exciting to see the synergy between the cost savings from a budget perspective, as well as conversations with people in institutions, in group home settings. Almost uniformly will tell you that they would much rather have a more community integrated setting, such as supportive housing. Massachusetts, as we said, begun in 2006, a partnership between Mahasa and the Behavioral Health Carve-Out, MBHP. It started as a cap of 50 using and this was a very interesting innovation here. They used the SAMHSA path provider for the state to act as an administrative services organization. It's important to remember that as supportive housing providers transition to using Medicaid for their supportive services, there's going to be that's quite a climb for them. The information systems they have, how they document their outcomes, how they document their daily activities is really not as labor intensive as one might expect in a healthcare related setting. So while many supportive housing providers are up to the challenge, they're going to need that assistance. It was exciting to us that Massachusetts used a current community health center to use that as an ASO and to support the supportive housing providers in the community. And again, Blue Cross Blue Shield did an analysis, 2007 to 2013, Blue Cross Blue Shield Foundation funded an analysis through Boston University's School of Social Work, and they found a return on investment in supportive housing between $1.61 to $2.43 for every dollar invested in the program. And there's a link here to look more at those outcomes. So again, we're looking at supportive housing as both a cost-effective, as a person-centered intervention, and as something that increases the community living opportunities for people with disabilities. Want to highlight the many different places where managed care has been a key partner, as more and more of our Medicaid populations are covered by managed care entities. Really want to shout out the places where the states have really taken that innovation and engaged around some opportunities to make managed care a more engaged partner in the community. Tennessee, interestingly, requires a housing navigator in their managed LTSS services contracts. And increasingly, you're seeing this job description, staff role at managed care agencies, at homeless systems called a housing navigator. Managed care is hiring staff with housing and social services backgrounds to work as these navigators. They can assist at the person level, helping people get documentation, helping people fill out applications for housing and things of that nature. They can work at the program level, where we're trying to expand supportive housing capacity and help currently existing programs develop a supportive services funding stream. And they can also operate at the systems level, high-level engagement between the systems to really set the tone and set the environment, and to address any initial challenges in that collaboration for the person in the systems level. So we're excited about that. Managed care is also working to create technology solutions to track opportunities for their members in the social determinants of housing space, including housing. So we've seen examples of different MCOs where they've created data systems that track social determinants of health. They track referral networks for key social determinants of health for their members. They track, say, food banks, or they track shelters. They track and align often with the homeless systems, information systems. We'll talk about that a little bit. So managed care is a key partner, and there's a lot of opportunities with states working together with managed care plans in this space. Given that we're focused on homelessness in this webinar for a healthcare audience, I wanted to just help folks learn a little bit about how the homeless sector works. Generally speaking, funding flows directly in the McKinney-Vento program or the Special Needs Assistance Program Office at HUD from the federal government straight to the communities. One exception to this is what you call the balance of state COC. So Continuums of Care is the local leadership around ending homelessness in a community. Most big cities, even small or medium-sized cities, may have their own Continuum of Care. Rural areas generally do not have enough infrastructure in order to support that, and so most of the states have what's called a balance of state COC, and this is basically collapsing the administrative structures and supports needed. It's important to remember that a lot of supported housing providers, because their funding, not all but many, because their funding comes directly from the state to the local communities, may not be very well connected or very well engaged at the state level. So it's important to engage them yourself, help them, bring them along, educate them in regard to how the healthcare sector works, how key the state level partnerships are. We talked about COCs or Continuums of Care. They're the local leadership around ending homelessness in the community. HUD in the last couple of years has put a lot more planning-related resources, what are called the HUD planning grants, into COCs and help them really reach out as community partners. It's important to remember that as we're talking about supportive housing, that this is one of a number of tools in the toolbox around ending homelessness. Folks who need supportive housing, these are primarily folks experiencing chronic homelessness. These are folks with significant disabilities who, without the supportive services as well as the affordable housing option, would likely not be able to continue to maintain in the community. They're much more likely, and decades past, might have been in institutions. There's a couple of other just key factors out there in the homeless system you may hear people talk about. Rapid rehousing is for individuals with short-term housing needs, helping them folks get back on their feet. This is often a common intervention for families, where the hope is that individuals will be able to secure employment, increase education, and then be able to afford the rent on their own long-term. Homeless systems at the community level are building what they call coordinated entry systems. This is the homeless sectors working towards having one front door for all of their resources so that everyone comes in through the same door, everyone is assessed, and then everyone is referred to the resource that best meets their need. This is really an attempt to both strategize, prioritize, target, as well as recognize the lack of resources in the housing space and making sure that the limited resources that are available go to individuals with the greatest need. Anybody in the homeless space will tell you, you'll hear them talk about the Homelessness Management Information System. That's the data system required by HUD. Every Continuum of Care is required to do them. And homeless systems are really increasingly able to partner, use their data with other sectors now that they have the quality data through all of the work that's been done over the last decade or so in regard to Homelessness Management Information System. And then a distinction I want to make in regard to, you hear a lot of work on Housing First. Housing First is really a phrase that's used in two ways. It's a phrase that means a philosophy that decreases the barriers, wanting housing programs, supportive housing programs, shelter programs, rapid rehousing programs, any program that works with people experiencing homelessness to have low barriers, to work to be able to screen people in, not screen people out. Then from the service side, a little more detailed is a more specific program model, which pairs an assertive community treatment model and evidence-based practice for SAMHSA with rental subsidies. That's one form of permanent supportive housing that tends to work with folks, often folks who have very long street histories, time living on the streets, folks that have significant behavioral health challenges as well. Housing First has been a great priority for HUD. I know I heard Secretary Carson last week at the National Alliance to End Homelessness meeting reiterate his commitment to the Housing First philosophy and model. So we are looking forward to working with this new administration in that space. These are just some of the key buzzwords as you're starting to partner with the homeless sector that they're going to talk about, that their priorities are, and it's helpful to know just a little bit about as you're building your partnerships with them. Another piece of resource that we want to offer as well is what we call our Medicaid Supportive Housing Services Crosswalk. This is a CSH signature product. We've worked with 8 states so far in order to identify these are the required services for quality supportive housing. These are the services and the populations that are covered under your state Medicaid plan. Here is where there are possibilities for opportunities, as well as here is where there may be gaps. So for these 8 states that have already been completed, please dust it off the shelf, pull it off the web, and go forward with it. For any other states, we are looking for some opportunities to do crosswalks as well. It's certainly clear to all of us that if you've seen one state Medicaid plan, you've seen one state Medicaid plan, so work is needed to be done in a number of other states. CSH also works with states to build their business case to ensure fiscal responsibility. We do training with supportive housing providers, with managed care organizations, and with state Medicaid offices. State Medicaid offices to educate around supportive housing, how it's funded, work like the crosswalk. With supportive housing providers in order to assist them in understanding the Medicaid billing processes, understanding their state and local contacts, the licenses, credentials, what information systems they will need, et cetera, to become a Medicaid biller. And then finally with the managed care organizations to educate them around the efficacy of supportive housing and how supportive housing can often assist with some of the challenges that they face. And finally, we do technical assistance with each of these key stakeholder groups as well as with housing authorities and other entities. So with that, I will say thank you for this opportunity again, and please be in touch.
Great. Thank you so much, Marcella. Really a fantastic presentation. And with that, I will pass it over to Liz in New York.
Great. Thank you. And thank you very much for having me participate today to talk about New York's Medicaid Redesign Team Supportive Housing Program. So here in New York, we are very committed to investing in social determinants of health because we believe housing is health care, and that for individuals who are either chronically homeless, street homeless, or unstably housed, that you can't truly impact and improve one's health without first addressing one's housing. In fact, experts estimate that medical care accounts for only 10% of overall health, with social, environmental, and behavioral factors accounting for the rest. So a lack of upstream investment in social determinants of health probably contributes to exorbitant downstream spending on medical care in the United States. So that's why here in New York, I think we've made one of the largest investments in the country using state-only Medicaid dollars to invest in supportive housing. And one of the key eligibility criteria for our program that's different for other housing programs throughout the state is that we target our high-cost Medicaid members. Another key piece that we really focus on is demonstrating the cost-effectiveness of our supportive housing program. We believe that investing in supportive housing is a wise investment, and so we've really built in a robust research and evaluation program to demonstrate how our program is in fact cost-effective and how it does in fact reduce avoidable hospitalizations and avoidable emergency room utilization. So our MRT supportive housing initiative is really a multi-pronged approach that funds various components within it. We have invested over $640 million over the last 7 years in our supportive housing program, and we invest in the capital construction of new supportive housing units throughout the state, and we also invest in rental subsidy programs and support service programs, as well as service and operating programs. And I mentioned, a key component is our tracking and evaluation. One of the things we want to demonstrate, not just by anecdote, but by Medicaid data, is that supportive housing really does save Medicaid dollars in the long term. And so what we've done is we collect the Medicaid identification numbers of every individual who resides in our MR supportive housing programs. And what we do is we look at what was Medicaid spend before the individual moved into supportive housing and what is it now. just to really demonstrate the impact both on the Medicaid program, but really to demonstrate how you can improve one's health when you create housing as an intervention. So when we created our MRT supportive housing program back in 2011, we worked with our MRT supportive housing work group to really try to focus on what populations throughout the state should we focus on. And what we learned from our stakeholders is that we really need to focus on a broad range of our Medicaid members who are unstably housed or chronically homeless. So we fund programs for individuals who have HIV/AIDS, who are chronically homeless, who have mental health, who have substance use disorders. We also focus on individuals who are physically disabled and homeless, individuals who are seniors, individuals living in shelter or on the street. We also created programs for individuals who were eligible or residing in nursing homes who could safely transition to the community, as well as individuals with developmental disabilities who could live in lesser restrictive settings. So our program is really a cross-agency collaboration with not just our state health department, but really with a variety of state agency stakeholders. We work with HCR, which is our Homes and Community Renewal Office, to assist with our capital program. And then we work with our Office of Temporary and Disability Assistance, our Office of Mental Health, Office of Alcoholism and Substance Abuse, our Office of Persons with Developmental Disabilities, as well as our offices within the Health Department, our AIDS Institute, and our Division of Long-Term Care. So it's really a collaboration, across the state to really create the best programs for the individuals we serve. To date, we have developed 19 distinct rental subsidy programs, and we've created 861 units through our capital projects, and we also have a projected 621 units in the pipeline. We've served over 11,000 high-cost Medicaid members to date, and we've also seen early successes in our programs, reducing avoidable inpatient hospitalizations, as well as reducing avoidable emergency room utilization and avoidable nursing home placements. So one of the interesting things that we learned through our research and evaluation project was that we are really serving the highest need individuals in the state who are on our Medicaid program. At first, what we thought was that maybe an individual who was chronically homeless only had mental health disorder or only had substance use. But what we've really learned is the clinical characteristics of our high-cost Medicaid members are extremely complex, and almost every individual suffers from more than one diagnoses type, and over half have one or more chronic conditions. So to date, we have invested $641 million since the inception of the program. We started with a $75 million investment, and that has grown to $107 million in 2018-19. The dollars are state-only dollars. We do not receive any federal share for our program, and it is funded within our Medicaid global spending cap, which essentially means that investments in one area, such as supportive housing, is really funded through savings in other areas of our Medicaid program. So I mentioned that we fund capital projects, and this slide really illustrates some projects that were funded by our MRT supportive housing program. And this is really our just a handful of our MRT capital projects that are currently operational. So we've funded 37 projects to date. From project close to fully operational usually takes 2 to 3 years. And so we started our capital program back in 2011, but we're very happy to report that 12 are currently operational, fully occupied, and serving a portion of these units in the building are designated for our high-cost Medicaid members. So one example of our MRT capital project is our Metro East 99th Street project. So this was our first MRT project to close in New York City. This is actually a picture of East 99th Street. It's a 175-unit building in New York City. And the focus for this building was really to serve individuals who are either chronically disabled or elderly, physically disabled, who are residing in a nursing home or hospital long stay or another facility within our New York City HHC system. And we made a $7.5 million investment to the project. It's a multi-funded project, but the MRT funded $7.5 million. And what we've seen to date is we have over 170% return on investment for the project, because what we were paying for was whether it was a nursing home stay or a hospital inpatient stay, we learned very quickly it makes much more sense to use dollars to pay for supportive housing, and we've seen great savings. And we've also, personally spoke to individuals who reside in the building, and it's a wonderful story. I think it's a great example of a project that is definitely could be replicated in other parts of New York or other parts of the country. So another capital project that we think makes a lot of sense is our Access to Home program. So this is really, the goal of the program is really a program to keep individuals in their current house for as long as possible. And what we learned was that there are individuals throughout the state who have a physical disability and who have various activities of daily living, need assistance with activities of daily living. And so we created a capital program for minor construction to an individual's residence, whether it's a wheelchair ramp or making their residence handicap accessible. What we learned was a minor investment in Access to Home can assist an individual to live in their home for as long as possible, and it avoids costly and avoidable nursing home stays. So now moving on, just to give you some examples of our rental subsidy program. So we also have various programs where we fund the rental subsidy for our high-cost Medicaid members. This individual program, our AIDS Institute Rental Subsidy Program, focuses on individuals who are chronically homeless, who have HIV/AIDS and live in upstate New York. This program began back in 2013 and funds several hundred rental subsidies for individuals with HIV/AIDS who are also high-cost Medicaid members. Another program that we created back in 2013 was our Eviction Prevention for Vulnerable Adults program. We heard from various stakeholders in the city of New York that there were individuals who are elderly and disabled who were at risk of eviction. So we worked in partnership with our Office of Temporary and Disability Assistance Office, as well as New York City Department of Homeless Services, who operates the program, to provide rental subsidies so individuals would not become homeless. And it has served over 200 individuals to date. Our next program was our Health Homes Rental Subsidy Program. When we created our Health Homes program, what we learned was that individuals were eligible and enrolled in health homes, but they were also presenting as homeless. In certain areas of the state, we saw at least about 1/3 of health home enrollment was homeless, and so we said to ourselves, we're never going to be able to really improve health outcomes if we don't address the housing situation. So we worked in conjunction with our health homes and housing partners and created this program back in 2014. We've served over 400 individuals, and this is a real key component that most of our other programs follow. We wanted to make sure that as we move some of our high-cost Medicaid members into housing, that we also linked individuals with our health home program to the extent they were eligible, to make sure that individuals received care coordination as they moved into supportive housing. So another program that we created back in 2013 was our Homeless Senior and Disabled Placement Pilot. This is a pilot specific to the City of New York for individuals who were living in the shelter system. It was really focused on seniors and disabled who were living in shelter who could move into supportive housing. This was another pilot that we created in partnership with OTDA and the New York City Department of Homeless Services, and we've served over 200 individuals to date. Another program that we heard when we discussed the creation with the stakeholder community was really the need to create additional mental health crisis and step-down units. And so this was a program created by our Office of Mental Health back in 2015 that really focused on individuals with a mental illness who were having a behavioral health crisis, and the goal was to move them into a step-down unit. It's a short-term stay program to divert individuals from costly inpatient hospitalization. The next program we created was our Nursing Home to Independent Living program. This is a program that we operate outside of within the State Department of Health. It began in 2014, and this was really a program designed at individuals who were either residing in a nursing home or nursing home eligible who could safely move into the community, and we fund the rental subsidy for individuals eligible and enrolled in this program, and we've served over 200 individuals to date. Our next program was created in consultation with OASIS, and this was really a program designed to assist rental subsidies for chronically disabled for individuals who had substance use. This is a housing first model. It's been a very successful program. Began back in 2013 and has served over 600 individuals. We also have programs with our Office of Mental Health that are designed specifically for individuals who have mental health and who are chronically homeless or unstably housed. This program was created back in 2013 and has served 1,151 individuals to date. We also worked with our Office of People with Developmental Disabilities. This program was really targeted at individuals who had a developmental disability who could live safely in a less restrictive housing setting. We funded the rental subsidy for this program, which began back in 2013, and we've served 70 people to date. Another program that was newly created, and this one is really, it was created back in 2016, and it's up and running. It's not fully operational. We've served 50 participants to date, but it's going to grow quite a bit as we fully operationalize the program, but it's really designed to fund rental subsidies for individuals who are eligible or in need of nursing home care but can safely live in the community. Another program that we created was our Special Needs Assisted Living Program, or SNALP. We like to create many acronyms here in New York. This program is another new program. Began earlier this year. It's a mix of capital programs and training projects. It's a program really designed to create, whether it's a memory care unit, specialized care for individuals with TBI, or safety monitoring systems to help prevent falls or wandering. It's really a program to assist individuals who currently reside in assisted living programs to assure that they live safely within assisted living, and some of these pilots are really designed to have them reside in their current setting for as long as possible. So as I mentioned at the beginning, we've really done a lot of work with research and evaluation, and we had a early findings report that we shared publicly a month or two ago, and we're very happy to report that an early look at our programs really demonstrate that they work, that we are really bending the cost curve in the Medicaid program with the creation of these programs, that we're reducing hospital inpatient days, we're reducing avoidable emergency room visits, we're reducing inpatient substance use rehabilitation, inpatient psych admissions, And the good news is we've also seen an increase in primary care, in prescription spend that individuals since becoming housed really can demonstrate increased health outcomes. And so we're very excited to see some of the preliminary evaluation results. This is a multi-year evaluation study, so over the next 2 or 3 years, we're going to come out with additional detail on the findings of our MRT supportive housing program. So thank you very much for the opportunity to present today. We have a ton of information on our website, and you can always feel free to email us with any and all additional questions. Thank you.
Great, thank you so much. And before I turn it over to Brian, just want to do a quick reminder that we are accepting questions for Q&A at any time. So in the bottom left hand corner of your screen, if you have a question, please ask it. We do have a few in the queue already, and those will kick off the Q&A period after Brian's presentation. So with that, Brian, you have the floor.
Hello, everyone. Thank you. You just heard my phone beep. That just happens when I take it off mute. But I want to thank everyone for the opportunity to talk about 2 of these programs that we're really excited about in California. You will certainly see a lot of shared themes from the 2 previous presentations today. So with that, I will get right into it. We're going to talk about our whole person care pilot programs and our 2703 Health Home program. So the whole person care program, again with shared themes, is an example of how over the last few years California has had an increasing emphasis on working with local entities to focus resources on frequent users of healthcare who have chronic conditions and are also experiencing homelessness. With the understanding that we heard about before that housing and other issues often have to be addressed if you hope to improve the condition of folks who have complex healthcare conditions and behavioral health issues. So what we have is a 5-year program authorized under our 1115 demonstration waiver to test locally based initiatives that coordinate physical healthcare, behavioral healthcare, social services, for beneficiaries who are frequent users of multiple healthcare systems or other types of local public service systems. The funding is $1.5 billion in federal funds through our 1115 waiver, which is available to match local public funding. This goes in with the theme with finding shared common goals with our local partners, counties in this case. Counties are the applicants and are leading and organizing this effort. It's up to $300 million that is available annually. It is based on semi-annual reporting of activities and interventions. So it's not quite like a grant program. It's also not quite a cost-based reimbursement program. It leans a little closer towards the cost-based reimbursement model, but there is semi-annual reporting of completion of deliverables and activities, and then these local pilots are paid based on the activities that they actually complete that are predetermined based on their application. The non-federal share is provided through intergovernmental transfer mechanism through our 1115 waiver. And we are in the first of 4 operational years currently. This program will run through 2020, and the first year was for planning and application. Next slide. So participating entities, as I mentioned, the lead entities in this case, which is a little bit different from how we would normally run this program, how our Health Home program is run. Normally our programs would be mostly operated through a Medi-Cal managed care plan. In this case, the local counties are the responsible entity, or one of these other organizations can take that lead responsibility. There is a requirement for certain participating entities, and the goal around that is to help bridge, key gaps in coordination that have existed historically between silos of care in a somewhat fragmented care delivery system here in California. One good example is that we have, each county has a mental health plan that is county operated that delivers our specialty mental health services to our Medi-Cal Medicaid clients. where we have separate managed care entities that deliver most of the physical health care. So bridging these gaps and helping with coordination is definitely a goal of this program. Other silos that we'll be focusing on in this program include housing providers, linkages with corrections, and other types of services. So the target populations, the goal is for the local pilot entity to work with their partners to identify issues in their local area and then develop solutions for those local issues. So what we have, currently we have 25 approved pilots. So you have 25 separate processes where folks went through a process of reviewing data, meeting with stakeholders, determining what specific issues they had to address the frequent user issues, and then designing solutions specific to their local problems. So you have 25 different applications with different strategies. Although they do have a lot of common themes, requirements, and target populations. So some of the target populations we have are those with repeated incidents of avoidable emergency use, hospital admissions, or nursing facility placement, folks with 2 or more chronic conditions, folks with mental health or substance use disorders, and folks who are currently experiencing homelessness or are at risk of homelessness. Additional populations that people have focused on, this list here is not exclusive, jail release populations for adult and youth, high-risk pregnant women, and folks transitioning from acute institutions, be it acute physical hospital transitions or psychiatric institution transitions. This slide, I think, gives you an idea of the scale of the populations that will be served under this program over the 4 operational years. This reflects the first round of applicants that we approved, which were 18. Since then, we have approved an additional 7 applicants and some expansion of the first round. So we have 25 pilots operating in 27 counties. There is one collaborative of 3 counties operating. So pilot activities and services. I think one thing that's reflected by this program is that folks are pushing the envelope on innovative services, and that in combination with trying to address all of the barriers to success in serving this population at one time. So you'll see this as I walk through the service examples. But there is an effort to not just take one strategy at a time on its own. There's a sense that it is the totality of the strategies all working together that folks think will be successful. So the core elements of the pilots include building infrastructure to integrate services among local entities that serve the target population, and through either collaboration procedures, governance activities, information sharing processes, data systems, and then second, to provide services to cover activities that are not otherwise reimbursed by Medicaid to improve care for the target population. And all populations receive intensive whole person case management in addition to whatever other individual services the pilot provides, examples of which will follow on some subsequent slides. And then all pilots are operating a Plan, Do, Study, Act process for quarterly rapid cycle quality improvement. Tenancy supportive services. So the majority of the pilots did select folks experiencing homelessness as a focus of their pilot. They may have selected other populations as well, or chronic homelessness may have been their only target population. But certainly the majority of our pilots are taking these services as far as they can for their populations. Tenancy supportive services, individual housing and transition services to assist folks obtain housing, individual outreach assessments, searching for housing, communication with landlords and coordinating moves, and then housing and tenancy sustaining services to support individuals in maintaining that housing once it is secured, tenant-landlord education, tenant coaching, etc. Now, I will note that this program does not pay for the cost of housing itself or rental subsidies, nor does it include building projects to increase housing supply. Housing supply is certainly always an issue. This program, I think, helps to focus resources in an effort for these folks. It will provide any services that are noted in CMS's 2015 Housing Services Informational Bulletin. There's a great deal of services that are mentioned in that bulletin that are available through this program. And this frees up funding from other sources to be redirected to housing. And we asked folks in their pilot applications to tell us if that was part of their plan, if they had another source of funding that they were counting on for actual housing. And that helped tell the whole story of what their pilot was going to do and how it was going to be successful in doing it. Yes. Additional supports: transportation that is not covered by Medicaid, environmental accommodations for accessibility, other one-time supports such as security deposits, utility setup fees, first month's coverage of utilities, one-time cleaning prior to occupancy, all these kinds of things. Additional innovative services that are approved that pilots could have included in their application is recuperative care, medical respite care. So this is up to, under our program, up to 90 days of residential care after an acute discharge, which allows folks to recover in a stable environment instead of returning to streets or an unstable environment where recovery is very challenging, where they may end up back in an acute situation very soon. Sobering centers for up to 24 hours of residential care to avoid emergency department or jail utilization. Field-based care, case managers, therapists, or nurses delivering services on the streets or at shelters where these folks are in the community. And benefits advocacy and legal assistance to help folks enroll in benefits such as SSI or remove barriers to benefit enrollment, to receiving health care, or to getting housing. So I will note that these pilots are working in their own individual areas on issues that have been barriers for a long, long time. Siloed services, fragmented delivery systems, coordination, information sharing, housing supply. Really, I think we say this is transformational work, and we recognize that this will not necessarily be smooth or easy, but that it is happening. And we have 25 different pilots, all with different strategies. There will be an independent evaluation of the effectiveness of all of these strategies, so we'll have very good information. That information can help us talk about how we can sustain these the effective strategies in the future once this program times out. Next program I'm going to talk about is our Health Home program, which in a lot of cases, in a lot of counties, local areas, they are thinking about the Health Home program in conjunction with how they're designing their whole person care program. And one of the reasons of that is there are some overlapping services that health homes can provide for people who are eligible once the health home spa come online. And that includes care coordination and some of these tenancy supportive services that can be provided by a housing navigator or another case management representative. So some context about our Health Homes program is that it begins a staged rollout in 2018, and it'll be available in most areas in California in 2019. Like most Medi-Cal benefits, this benefit will be administered through the Medi-Cal managed care plans. Plans will contract with community providers such as FQHCs for most services. State legislation requires program cost neutrality, so there will be a focus on evaluating savings in inpatient and ED, et cetera. That requirement has, we are certainly thinking about that requirement as we've designed the eligibility criteria, the service package, everything else is designed with cost effectiveness in mind for this program. Eligibility includes specific physical and behavioral health conditions. State health homes legislation was co-sponsored by the Corporation for Supportive Housing in California and includes frequent users who are experiencing homelessness and some specific requirements for providers who provide health home services to folks who are experiencing homelessness. And eligibility is focused on the top 2 to 4% of the highest risk frequent utilizers who are living in the community. So SPA supportive services, housing services under our SPA. Currently it is under review with CMS. The draft SPA includes tenancy supports referenced again in CMS's June 2015 bulletin about housing services. Same types of services we saw earlier that are available also in whole person care, individual housing transition services, individual housing and tenancy sustaining services. These services fit within the definition of health home case management and fit the need of our population. And coverage is not available for one-time setup services such as housing modifications, first month's rent, deposit. So those services still, the only availability would be under the whole person care pilot. Now, some context about service requirements that relate to services for folks experiencing homelessness. Plans have the flexibility to organize the provision of their services with their community providers to maximize effectiveness. So they, for services like engagement of homeless members, they can be subcontracted to providers that our managed care plans have not traditionally contracted with, such as those in the community who have expertise in working with and engaging homeless members. The health home service team will include a housing navigator. Managed care plans will provide services to members in the community. So this will not be a telephonic case management program. This will be meeting folks where they are in person in a lot of cases. Managed care plans will use local-based providers with experience serving homeless members. And there will be reporting requirements for us here at DHCS to track members who have been homeless, their services, and the effectiveness in improving their housing status. Some resource assumptions are important context for this program and how it's going to be effective with these services. DHCS will develop a capitated risk-based add-on payment for each enrolled member, which will be paid to the managed care plan. The plan then will in turn develop their own rates and contract with their providers to deliver the actual services based on the requirements that DHCS has set up for the program. In the development of the rates that we pay to their managed care plans, we at DHCS are considering additional resource needs that can impact program success for homeless members. Resources for members with varying levels of acuity and complexity, including behavioral health conditions, may require a higher resource allocation. Engagement efforts to get members into the program. So calling or sending a letter in a lot of cases will not work, and this is going to require additional resources for successful engagement. And higher levels of initial resource utilization for new members. And then program monitoring. So case management and care coordination of services like are expected under the health home program that address the whole person are new territory in a lot of cases for the organizations in our healthcare delivery system, our managed care plans, our FQHCs. And they have generally focused on physical health care. So we'll be designing a lot of outreach and technical assistance and program monitoring to ensure that the vision of whole person care, including behavioral health, housing services, social services, that vision is being translated down into the field and being fulfilled. So the plans have flexibility to contract for services and rates to meet the specific needs in their areas for their providers. will verify that the managed care plans have a viable model for a complete network of providers to meet all service needs, and that provider contract requirements, a payment model, and an oversight process to ensure higher need members receive higher levels of service. And through our monitoring processes, we'll also compare actual managed care plan resource utilization to the initial rates that we developed and the assumptions that we used about resources to develop those rates, and our program service requirements to again, make sure that vision is translating successfully. And we have some resources available at our webpage, definitely under the Whole Person Care Pilot webpage. We have lots of information, detail, including the full PDF pilot applications for each of our 18 right now. Very soon we will have the additional 7 pilot applications posted as well. And then on the Health Home program website, we have a fairly detailed concept paper that lays out our model for health homes and lots of other information. And with that, I will turn it back over. Thank you.
Great, thank you. And thank you again to everybody, as well as everybody who's putting in such fantastic questions. It is time for Q&A, and we're going to kick that off with a few user-submitted questions. And the first one was asked specific to New York, but it definitely applies to all of our speakers. I'd like to expand the question out. So first, I'll start with New York in terms of the MRT program specifically. Does that provide support for populations transitioning from state correctional facilities back into the community? And then for the other speakers, I'd love to hear your perspective on, ensuring warm handoffs as individuals enter back into the community into either Housing First programs or just more in general being connected into the housing system. So, Liz?
Sure. So we don't have a specific program designed specifically for individuals transitioning from state correctional facilities back into the community. However, I will say that some of our programs, our OMH, MRT supportive housing program, as well as our health home pilot, a few providers who participate in those programs chose to really target individuals who are transitioning from state correctional facilities. The long and short answer is yes, they are covered, but it's not a distinct program.
Great, thank you. Brian?
Yeah, for our local whole person care pilot programs, I would say the majority of emphasis is because they are operated by local counties. The greater emphasis is on local county jail release populations, both youth and adult, but certainly these services are available to folks who would be transitioning from state correctional facilities. However, they may come to the attention of the local pilots. For our health home program, we are developing from our own administrative data targeted engagement lists that we will be giving to our managed care plans. So it may encompass a number of folks who happen to be transferring from a state prison, but strictly speaking, no, there is no direct engagement or transition plan for that.
Great, thank you. And Marcella, I'm very curious to hear if you've seen some best practices emerging or some trends nationally that you'd like to bring up in this discussion.
Sure. A couple of things. New Jersey's 1115 waiver is asking for Medicaid eligibility upon the date of release from long-term incarceration. Illinois' 1115 waiver is actually asking for Medicaid eligibility 30 days before release from long-term incarceration. For behavioral health population in particular, what they're trying to do, particularly in the Illinois program, is ensure that not only do people have an appointment that can be kept for services, but also that they really have that warm handoff you were talking about. So it's not just, I'm going to clinic A, it's, Joe came in to see me in jail, in the prison, I'm going to see Joe on Tuesday at 10. not I'm going to this address or I'm going to this clinic. The hope is that that will ensure that more individuals are able to stay connected to services upon release of incarceration. I'd also highlight the Ohio statewide program called Returning Home Ohio. They do an assessment for individuals leaving long-term incarceration. They make determinations about some folks need permanent supported housing, other folks need rapid rehousing, shorter-term supports. Still others need family-related supports. They're going home to family but will need other supports. And so that's a statewide program that assists people in the transition with a supportive housing perspective. But again, it's a limited resource, so there is analysis done to determine who has the most need. The other really exciting programs I've seen on this population have been both, actually I think it was last year at the NASHB conference, was Ohio and New Mexico had both been working with their managed care organizations in order to determine who were going to be the next quarter's high cost, high need folks when they leave incarceration. So I may be leaving jail for 20 years after 20-year sentence, and I may have HIV and a history of substance use disorders and COPD. And so for a very small targeted number of individuals, managed care programs are going in, engaging the individuals behind the walls, and again, doing, as you said, the warm handoff to ensure that it's not just, or here's an appointment or here's a, go here, but really to try to build that relationship with the individual to ensure that transition is a successful one and doesn't lead to homelessness. So some good opportunities and models out there.
Great, thank you. So our next question is in terms of functional status assessments or medical assessments. I'm curious to learn from both states and then again from a more national picture in terms of, are you using a standardized assessment tool? If so, is it a public one? I know that we did receive one comment saying it would be helpful to get a copy of New York's if possible. If just any information you could provide on the sorts of intake tools that you use to help navigate folks to supportive housing services would be really appreciated. So this time I'll start with California.
Yeah, so for our whole person care pilot program, we do not have a standardized intake tool or assessment tool. We do have a learning network set up for the pilot entities, so one of the things that they've been interested in sharing amongst themselves are good tools that they have and are using. So if somebody were looking for a recommendation, we could probably point them in the right direction to another person who might have a good tool. For our Health Home program, again, we will not have a standardized tool, but in that case, for our Medi-Cal managed care plans, we will have a policy about a standardized policy for what elements have to be addressed as part of the assessment. So it's one step short of actually one standardized tool. It will specify that kind of further that whole person approach, that all of the appropriate needs are addressed in that assessment and tool.
Thank you. New York?
Sure. So, we really have a variety of assessment tools that we use to assess, who's eligible and should be enrolled in our housing programs. Down in New York City, there's the 2010E, which is really a very universal housing tool, but that's specific to the city of New York. For some of our long-term care programs, we have a universal assessment tool, which really tries to analyze on different levels how many activities of daily living an individual needs assistance with. OASIS, our OASIS program, has a unique tool which really they use to help prioritize individuals to participate in that program, and what they really used was a tool to assess Medicaid utilization on the inpatient and emergency room side. And then, for our capital projects, we use an assessment tool, both the 2010E for New York City specific capital projects, but we also look at, the top 20% Medicaid spenders who are eligible for that project. So I think, there's various tools out there. We also have our Health Home assessment tool. We can certainly share, a variety of these that I spoke about, so folks can, see some of the different assessment tools that we use depending upon the program.
Great, thank you. And Marcella, I'll send it to you, the same question, but also I'm wondering if you could, at the same time, kick off the next conversation in terms of eligibility data as well, and thinking about, you mentioned the HMIS systems in your presentation. So after you talk about the assessment tools that you've been seeing states adopt, if you could talk about state strategies in connecting Medicaid data with the HMIS data, that'd be fantastic. Thank you.
Sure. Yeah, this isn't an area that I have a great deal of expertise on the assessment tools. I will say that the homeless system has used, the National Alliance to End Homelessness has an assessment tool there. There's also a tool called the Vulnerability Index, or the VI-SPDAT, that is commonly used. Those generally don't have, they're focused on trying to determine what in the homelessness system toolbox is really the right intervention for an individual. So they're really not looking at clinical functional assessment. I'm happy to share a tool that I used in my old role with a behavioral health MCO that used that, if that would be helpful. But again, because it was a carve out, it was much more focused on the behavioral health side than on the physical health side and the best practice of integrated care. And exactly right. I think that the first iteration of this work will be done using assessment tools. I think the second generation of this work will be using matching data systems. So communities increasingly have good quality homelessness management information systems, and we've worked in a number of localities. We worked with United Healthcare in Houston, Texas. We've worked with other states and communities to determine who's the most vulnerable from a service utilization profile, among that, who is really who is a priority for both the homeless system as well as the healthcare system, and then how do you ensure that the limited resources in supportive housing go to those individuals? And really, those data matches, I think, really have two agendas. One is, as I said, an individual level agenda, but it's also really an opportunity for the healthcare and the housing sectors to come together and make some determinations about how much crossover do we really have. We're really excited about the ICD-10 includes codes for homelessness as well as unstable housing. We're really trying to encourage both states and MCOs to use that data, to look at that data, to really look at the data quality of those codes and see. When we've done the data message, we've seen the healthcare sector generally surprised at, in the Medicaid space, of course, at how many of their members have been experiencing either homelessness, chronic homelessness, or unstable housing. So, I think first generation is assessment tools. Second generation will be these data matches that not only try to address the complex care populations as well, but really bring the healthcare and the housing sectors together for long-term partnership.
Great, thank you. And for our state presenters, I'm curious if you have anything you'd like to add in terms of connecting data systems or working with the state's HMIS systems to have a better idea of who maybe outside of care, or how to better connect to your health and housing programs. And either can volunteer to go.
Yeah, so this is Brian in California. Certainly our whole person care pilots, part of their application process was to come together with partners and share data and look for overlapping populations. And so there are varying levels of to what degree that was done in various pilots. Certainly some of the pilots are taking this to its maximum and sharing data from, half a dozen different organizations, be it local jails, hospitals, Medi-Cal managed care plan, the HMIS data system, and others, behavioral health, mental health plan, and coming up with overlapping lists of folks who are using services. Others are using the assessment route more, and maybe they're talking to and assessing everybody who's coming out of local jail on parole to see if they meet the eligibility criteria. So there's just a lot of different types of activities happening in the same program with the various pilots. And for our health home program, where the state is producing its own sort of engagement list, target engagement list, We are not tapping into the HMIS systems at all for that, but we are combining all of the available Medicaid data that we have from our various systems, our medication payment systems, our specialty mental health data systems, and our Medi-Cal managed care encounter data that comes in, and other fee-for-service types of data to make sure that we're getting everything we can and we're not missing anyone.
Great, thank you. Liz, anything to add from New York?
Sure. So we have, multiple data sets, but no universal data set that really links our Medicaid data to our homeless populations. We do have, with our health home eligibles and enrollees, there is an indicator where someone can present as unstably housed or homeless. One of the first populations that we moved into Medicaid managed care back in 2011 was our homeless population. So our managed care plans do receive rosters of who's homeless, so they can identify individuals who are homeless in that data system. But I think, we're really still trying to work towards a universal data set to identify homelessness and Medicaid members. We do have, our Medicaid data warehouse, but there isn't, a universal tool where we can do a data run to identify all of our Medicaid members who are homeless throughout the state.
Great, thank you. So the next question is actually referring to a specific slide, which I'm going to go back to, and Liz, it was in your presentation, in terms of the evaluation results. So the question, there's actually two that I'm going to combine. So in terms of these results, are these a combination of results from all of the different programs that you mentioned? Are they specific to any one program? And then the other question that's semi-related is, does the data, are these results indicative of while folks are receiving the housing services, or are they perhaps a year or two out when they may be more stably housed and not receiving as many stabilization services?
Sure. So our evaluation report, and I think I mentioned this during my presentation, but we did provide a link in the slide deck for folks to access it and read it. But our early look really just focused on our first 11 programs, and that's really because they were created back in 2011, 12, 13, some of our earlier programs, just to give us a full year's worth of data for when an individual was in our housing program. And we also needed to look at 12 months prior to the individual moving into housing. But what we do is we collect the Medicaid identification numbers of every individual who participates in the program, and we run it through our Medicaid data warehouse. And, in the report that you can see that we show by program and really by utilization type, how we're driving spending, specifically, whether it's inpatient, outpatient, emergency room, primary care, pharmacy. There's really detail to see, how we're really driving spending or saving spending. But it's all for individuals who are currently participating in the program. We also do follow individuals who leave the program and follow why they left the program. So that was another important piece to our evaluation to study. And this really was just our preliminary first look. Over the next 2 or 3 years, we're going to have more in-depth analysis of more programs because they've been operating and fully operational to give us enough data to really, share some early results and key findings.
Great, thank you. And Marcella, I'd like to ask you a related question in terms of, you talked about the braiding of funding and braiding of funding authorities, and it could come from different agencies. So for evaluation purposes, do you have any tips for states as they think through how to evaluate their programs, knowing that the savings might be coming from different agencies or being applied to different agencies? Any tips that you have for attendees on that would be really helpful.
Yeah, I think the states where we've seen most effectiveness has been often a collaboration with a research university that really merges the data across. So it's different data sharing agreements with each different state entity, obviously having to follow the rules of each, but then it's often the academic centers that have both the computer power as well as the ability to build that cross-sector data system. We've also seen some data warehouses. I think folks have heard often about Allegheny County in Pennsylvania has one of the really best functioning data warehouses, and that allows you to do the aggregate data matching across. Most of these data matching are often one-time initiatives, and the hope is that they will build over time in order to be more common and more more continuous. This is not really a one-time issue. We wish, but it's not.
Right. And so, Brian, I'm going to turn it over to you, but I'm going to give you the option to either add on to this question or kick off conversation on our final question. We are nearing the top of the hour. So the last question we received was about certification and licensing standards for supportive housing services. So any sort of tips or information that you could share in terms of helping non-traditional Medicaid providers start to provide some of these services would be really helpful for the audience.
I think one of our goals, being that California is big, diverse, different managed care plans operating under different models. They have different service provider availability in different areas. So we've tried to be real flexible in the guidelines that we've set up from the state level. Having said that, we are asking our managed care plans to give us an application to describe how they're going to translate our requirements into their specific model for delivering health homes. And I think as part of that, we will be looking at how they are selecting and what types of providers they want to use for services for folks experiencing homelessness, from engagement to navigation and other types of services. But I know that community health workers are one of the available provider types that can be used, peer support workers. So we're trying to build in the flexibility where we can, and then if we see a situation where we need to take it back a little bit, then we'll do that as needed. But we do not have any hard and fast requirements on certification or anything like that.
Great, thank you. Liz, any certification or licensing requirements for New York?
Yeah, so I think the short answer is we did not create any new licensing requirements. We just, obviously want to make sure that anyone participating abides by the current regulations and state licensing laws that are currently in the books. But we didn't create a new requirement through our MRT program.
Great, thank you. And Marcella, you will have the last word in terms of anything that you're seeing nationally, trends, best practices in this area.
Sure. I think Louisiana's actually done a really extraordinary job when they built their program in that they used a mix of, and I believe there's more details of this in the brief that you all just put out in regard to Louisiana and braided funding. When I say you all, I mean NASHB. In regard to some of the requirements that they put forward, as I recall, it really needed to be a clear mix of folks needed to have long histories in their community. Provider agencies needed to have some expertise around the supportive services and some expertise around the housing. They were really looking to bring more partnerships together than they were, any one entity, because there were so few entities that had that information. But I would refer folks to Louisiana. And they've been doing it for 12 or 15 years. These are great questions, but these are questions that, when you're, just starting something, or even a year or two in, like New York is, I might suggest folks look to Massachusetts or Louisiana for some more details on that.
Great. Well, thank you. Thank you all again for your wonderful presentations and being available for the questions and answers. I want to remind folks that we do have a brief evaluation that's going to automatically pop up when I stop the meeting. We please ask that you do complete this. It really helps guide our work. We want to make sure that we're meeting your needs, and you will have the opportunity to give us any feedback in terms of future work that you'd like us to focus on, and we really do take these to heart, so we really do appreciate your time. It shouldn't take you more than a couple of minutes. So thank you all again so much. I hope you have a great rest of your day, rest of your week, and if there's anything, any questions that come up, please go to nashb.org and get in touch with us. So thank you so much. Bye.